Welcome, everybody. My name is Kelly Piper with the California Healthcare Foundation, and we're going to be getting started with the webinar in just a moment. Welcome to the webinar on accelerating opioid safety. My name is Kelly Piper, and I'm a family doctor with the California Healthcare Foundation. I've been working with the foundation and other partners across the state on the opioid epidemic for the last few years, and I'm very excited to share with you this new publication coming from the California Quality Collaborative. For those of you who don't know us, California Healthcare Foundation is dedicated to improving care and outcomes for low-income Californians, and one of the areas that we work on is improving better care for behavioral health conditions, and so our work on opioid safety comes from that. I'm going to spend a few minutes talking about some housekeeping and logistics, and then introduce the project, and then turn it over to our facilitator. So to kick this off, I just want to share that where we are in this epidemic, and we do have some reassuring signs that total opioid deaths in the state have stabilized, even dropping slightly. And overall, our prescribing has dropped dramatically. We've almost cut opioid prescribing in half across the state compared to our peak in 2010. Yet, nevertheless, we are seeing escalating rates of heroin and fentanyl overdose deaths. And so the work is in no way near done. And if it were just a prescribing problem, we could wash our hands and say we've done a pretty good job. There's still more work to do, but unfortunately, we're seeing the shift from prescription opioids to heroin and fentanyl, and we as a community, as a healthcare community, need to step up and make sure that there's a no wrong door system of care. So no matter where anyone enters the system, whether it's in a primary care clinic or a hospital, an emergency department or a jail, they're able to get compassionate screening for any substance use disorder and get the treatment they need. So we're working across the state on this model of treatment starts here. No matter where you are, you can get treatment. So let me say a word about housekeeping, if you could advance the slide. We, just because we expect a lot of people on this call, all lines will be muted. If you have a question, we really encourage you to submit that question through the question and answer platform at the bottom of the screen. So don't use the chat function, but use the question function. That way we can collect questions during the presentation and make sure they get addressed. The recording will be available to everybody. The slides and the recording are on the CHCF website, and the toolkit is also available at the California Quality Collaborative website. So just before I hand it over to Crystal, let me say a word about where this project came from. Smart Care California is a public-private partnership of the biggest public purchasers in the state. So Covered California, which is our health exchange, Medi-Cal, covers low-income Californians, and CalPERS, which covers all government employees and retirees. And they all got together and said, we together, the purchasers of healthcare for over 40% of the state, could make an impact to make sure that all care that's delivered is safe and affordable, and that we avoid waste and harm. So the three things that Smart Care California decided to tackle were the opioid epidemic, overuse of inappropriate interventions for low back pain, and excessive C-sections. We've made amazing progress on C-sections, and our average rate has dropped down to the national goal, and we're still doing a lot of work on the opioid epidemic and low back pain. One of the things we talked about in Smart Care California is our strategy. How do we address this epidemic? We need to work on the prevention side and make sure that we're using opioids for fewer diagnoses, for shorter durations and lower doses, so that fewer people go down this path of opioid dependence and even addiction. We need to manage pain safely for the people who have been made dependent on long-term opioids. Doctors like myself, thinking we were helping people, have put patients on very high doses, and they come to profound harm if they're suddenly cut off or tapered too quickly. So how do we help manage people on these high doses? And then how do we treat addiction effectively at all points of care? And until people are ready to get addiction treatment, until we have enough addiction treatment, how do we stop deaths through harm reduction? And this toolkit is designed around that four-part strategy. One of the things we found in Smart Care California is even if you know what you're supposed to do, we know we need to be working in all these 4 areas. It's not always clear how to do it, and that's where California Quality Collaborative absolutely excels. They've got a long track record in helping provide organizations, clinics, private practices in the hard work of clinical transformation. How do you implement what you know you need to do and create systems and structures so that care happens consistently? So Crystal Eubanks, who's the Senior Manager of Practice Transformation at the California Quality Collaborative, will be taking it from here, facilitating the orientation to the toolkit and introducing you to some guest speakers who she will be introducing. Rachel Mashburn from CedarSinai and Susie Foster from Hill Country. So Crystal, could you take it from here?
Yes, thank you, Kelly, and good afternoon to everyone. I hope you're catching a bite to eat or possibly getting a brief respite between busy clinic sessions this morning. Yes, I'm very excited to not only release our toolkit and talk about it, but most importantly, hear about improvement work in action, right? There's tons of toolkits out there, tons of ideas, but I'm very excited to welcome Rachel Mashburn from CedarSinai Medical Network and Susie Foster from Hill Country Health and Wellness Center to share later on in this webinar their stories of improvement work around opioid safety. So not just what they're doing right now, but part of the evolution of how they've tackled this as an organization. So as we introduce them later, we'll give a few more details about their organization. So today we heard a little bit from Kelly about the California landscape and the current initiatives through Smart Care. We're also going to be digging into some data around different aspects of the 4 improvement strategies that she shared, just to familiarize ourselves and really get to know what we're dealing with, and subsequently which change ideas, which tactics are really most impactful right now within California. We will share the link to the toolkit, which is thank you, Child, is already in the chat box if you want to go ahead and start downloading that. We will dig into the actual change interventions that our key informant organizations identified as the most impactful in their work and that really drove performance and outcomes for patients. We'll hear from Rachel and Susie and open it up for questions for you guys to pick their brains, hear more about what they're working on and what they're excited about. So before we jump into this, I want to acknowledge that the opioid epidemic affects us all, and there's different reasons that we showed up to this webinar today and have taken the time to focus on this. And so to get us in the right frame of mind, I would love you to just reflect for a moment about your reasons for joining this session today, right? And we have a few options. So what motivated you? Someone you know personally, work things, either it's important to your organization or it just impacts you and your work. Or maybe you're just interested in learning about quality improvement efforts in the state or what organizations are thinking about. So we'll give a moment for you to let us know. Okay. Looks like most of you have let us know. Oh, some quick changes. So challenge, share those results with us so we can get a sense of where everyone's coming from today. So I see that the majority of people said that opioid safety is an important issue at my organization. So that's great. This is going to help drive actions and give you some insights and ideas about what to do to make some changes within your organization. And it looks like we have a lot of people that are interested in learning about quality improvement efforts and what organizations are doing. So hopefully we'll meet all of those objectives for you as we go through. So here is the toolkit. There's the link. It's available for download now. Share it widely. I just want to share in the development of this this toolkit in partnership with California Healthcare Foundation and Dr. Kelly Pfeiffer. We really wanted to create something that was very tactical, right? We know some general improvement strategies where so much is coming through the news, through new evidence around opioid safety, but what can we get to the very tactical changes that have driven outcomes and that have demonstrated some data that show that, and not just the anecdotal ideas we sometimes hear about. And most importantly, I'm a big believer that within California, it's really important for different segments of healthcare to learn from each other. So we wanted to create a toolkit that addressed and highlighted innovations in both the safety net providers, so some of our community health centers, and those serving Medi-Cal and Medicare, and our commercial organizations and populations, right? And so this is something that affects us all, and what can we learn from both sides of those parts of the healthcare sectors to exchange ideas and really generate forward momentum. So we started developing this in the beginning of the year, and it grew and grew in a way that I personally did not expect, but in that there were so many ideas and people to interview, and so this became a very large document. But as we were doing that, the ground has been shifting underneath us, right? New evidence coming forward, new resources are becoming available, right? Everyone's really jumping into this work, and so we tried our best to bring all of that in even as it was coming at us, and getting close to a final, and then we added some more. So hopefully that will meet your needs. I just want to take a moment to acknowledge some really important people in the development of this toolkit. I'd say most importantly was our informant organizations. We have 16 organizations across the spectrum of geography, size, patient population served, and a few partners that aren't within ambulatory care, but partner with ambulatory care organizations to give a more comprehensive and holistic view of improvement efforts and partnerships going on. And then I also want to acknowledge our advisory group members who are instrumental in guiding us in the development of this, prioritizing what questions to ask, and giving us really expert review in our drafts. So thank you very much to all of you. So as Kelly mentioned, out of Smart Care California and the California Healthcare Foundation, they've really identified 4 improvement strategies related to opioid safety. Right, and a quick recap, right? First and foremost is about preventing new starts, so it's really focused on safer prescribing. Second strategy is really managing pain safely, and so for those that are already taking opioid medications, that we're finding safer regimens so that we're reducing their risks. Third, for those that have opioid use disorder and are struggling with addiction, that we are treating them effectively with the medications available to our providers and our systems, and meeting them wherever they access care at their point of need. So, right, so not just in the ambulatory care center, but other places, and how we partner across the healthcare sector to make sure that, as Kelly said, there is no wrong door. And then lastly, stopping overdose deaths through harm reduction, whether that's naloxone or needle exchanges. So I feel like as we talk to our organizations, we didn't just ask, what are you doing? And what are you doing in each of these? But what was your journey as an organization to, conducting improvement efforts in all of these strategies, because there's not one single idea that was going to make movement within an organization and really impact patients in a way that they need right now. So we really asked about their journey, but use these improvement strategies as our kind of guiding framework as we jumped into those ideas. And as we asked these questions, we realized that we started hearing about a common journey. And we share this in the toolkit in some more detail. But the summary is, this journey as an organization is that all of the organizations started with very passionate people that were piloting small changes. And foundational and fundamental to that was that their leadership encouraged them to do that, to go out there and just try something, right? And once these passionate people were piloting small changes, seeing some impacts, then they worked to get leadership support. And whether that's a champion, resources, or attention, or just the meeting time, so that they could convene a multi-stakeholder group across their organization. And I say multi-stakeholder group was what was critical to many of these organizations, was to have clinicians at the table, but also operations folks, pharmacy folks, different people across the organization, because they could leverage resources from multiple departments, but also these perspectives, because patients that are struggling with pain are impacting so many different departments staff within our organizations. And as the group got going, right, that they really worked as an organization to standardize prescribing of opioids. So looking at safe guidelines, when to prescribe, when to find alternative treatments for them. And then they were monitoring the compliance with those guidelines and really working hand in hand, elbow to elbow with many clinicians and care teams to redesign or change workflows so they could prescribe in compliance with that. And then once that was, they gathered momentum, they have communication across the organization, they expanded their safe prescribing to other drug types and med combinations, and then really jumped into treatment, so treating addiction, in that they've had enough communication and socializing of the work around opioid safety that they could harness all the resources, all the energy and momentum to really do some deep process changes to provide addiction treatment to patients. So within the toolkit, just a brief overview, we've taken each of these 4 strategies and applied the model for improvement. I would be remiss as a quality professional and someone who's passionate about quality to not use the model for improvement when I can. So we laid out for each of these strategies, what are you trying to accomplish? We incorporated measures that the organizations shared with us that they are collecting data on and monitoring within their organization. So you see some impact in the measures that they are using. And in the appendix, there's some details around the specifications. And then we detail in several change categories what are the change ideas that these organizations are using. Some of these ideas could be very generic, like reviewing county level data, but some of them get very specific about which types of screening tools or assessments or education materials they're using. So for each of these kind of categories of changes, the ideas are there, as well as the resources specifically for those change ideas. And as we interviewed and collected the information from our organizations, we really saw that there were 8 change categories that people were working within. So they're addressing data and transparency and bringing that and making it accessible to people, leveraging health information technology, whether it's EHRs, registries, telemedicine. They're really developing their workforce, so developing both the capability and capacity and the knowledge around that. They're addressing clinical practice in terms of different workflows or supporting clinicians in their decision making. And of course, leadership is important to any change, and really championing this work and supporting it with resources. And access to care becomes very important about how patients have access to the right kind of care, and as well as patient and family engagement and working with the community through supporting efforts within the community and engaging other partners. So you'll see for each of these areas, we've listed the change ideas and resources. And in today's webinar, we're just going to focus on the ones that I've seen as the most impactful and where most organizations are working, but all the details are there. Okay, I want to pause real quick so I can take a sip of water here. But to think about, for those of you where this is important for your organization and you're actively working to impact opioid safety, which of these strategies is the top priority for your organization right now? And Challen's got that poll up for us. Okay. Responses are still coming in. And Challen, can you share those results with us? Okay. So it looks like of those of us gathered today, most people are focused on preventing more prescriptions. And it sounds like, looking from the data, we've done a lot of work in this, but the organizations are still trying to get a handle on this. And then it looks like the second group is actually jumping into treatment, and so how to meet the needs and work with individuals who are struggling with opioid addiction. Great, so this will help us focus some of our talks, and if you have questions throughout as we share, please feel free to write those in the Q&A. You don't have to wait for the end, and we'll address those as we see them come up. Okay, jumping in, strategy one, about prevention. So I'm also a data person, so I had to put a few graphs up here. Just a quick shout out to the California Opioid Safety Surveillance Dashboard. The links both within the slide deck, but also within our toolkit, have some amazing data that drills down to the county. It pulls from public health departments, it pulls from cures to help us really get a sense of how to target our efforts. And what I want to highlight in these two graphs that yes, opioid prescriptions are going down, right? And this is wonderful news. And many of our counties are still struggling with high rates of prescriptions. And so when we think about how to target some of our efforts, and for those of you that are still working on prevention, that you may be some of these counties on the right that are highlighted with the darker colors, right? So there's still a lot of work to be done. For these organizations that we interviewed, for this strategy, what made the most impact in their improvement work was really leveraging their health information technology. It was about visit templates in their EHR for pain management, right? Just both dealing with acute pain and chronic pain, but having those visit templates in there for providers to document consistently and get to the level of detail to help make a choice with that patient. They brought in pain assessment tools, and they had patient materials for pain management within the EHR for easy distribution with patients and to facilitate those discussions. And many of them were building in some decision support to guide safe prescribing. And so if a provider was choosing to start a new start of opioids, then they were able to give some decision-making guidance about the level of the dosage that should be prescribing. And our second place that we saw a lot of efforts that were most impactful in prevention was around access to care to alternative pain management treatments. And so some people did this through group visits. A lot of groups did this in the safety net, but also in the commercial side about bringing people together in a group to talk about chronic pain management. And but they were also working with their health plan and local coalitions to spread the information and accessibility of alternative treatment techniques, and so that they know where to get access to those treatments. And lastly, we'll hear from CedarSinai today about thinking through how you create kind of service packages for chronic pain management so that patients have access to several choices so they don't feel like their only choice is an opioid. For strategy two, it's really about managing those patients with chronic pain that are utilizing opioids that to get them to find a safe treatment plan, right? And this data right here is that we see that the MMEs of opioids, the morphine milligram equivalent, is going down within California. So that is good news. And on the other side is we actually have many counties that have high rates of prescribing both opioids and benzos at the same time. And we know that this is a safety issue and it puts them at risk of overdose. And so there's several different elements of safety and finding what is a safe treatment plan for a patient. Again, organizations leverage their HIT for this, and they created a lot more alerts within their EHR when it was prescribing outside of guidelines, high doses for new starts, concurrent prescriptions, and checking cures, which is now the requirement, I think, as of October 1st. And so just prompting clinicians and often sometimes care teams to do some of that checking where possible to help manage safe care. And some of organizations, particularly larger ones, were thinking about deactivating specific unsafe medications. There was not a consensus about whether everyone was doing this, but it's something that several of them were trying out. But most of them were integrating screening tools for substance use disorder, and they were really managing these patients a little more closely using data through creating kind of a sub-registry of patients that were chronic pain patients on opioids. They were also jumped into a lot of work with clinicians, and so clinical practice, and you'll see in the toolkit, there's an entire page devoted to this of all the work going on in clinical practice. And so in addition to the usual guidelines and policies that any good QI toolkit will tell you, they were doing a lot of work of prescribing buprenorphine for managing pain instead of opioids, co-prescribing naloxone as a preventative, right? And also to initiate discussions about weighing that decision with a patient about what are the harms and benefits of opioids and when might the harms outweigh the benefits, and usually using that prescribing of naloxone as a catalyst for that conversation with the patient, and working collaboratively with patients. And I know we generically say this, but this is about working alongside with a patient to customize their plan. So customize tapers, avoiding these involuntary tapers, like not quickly, not fast tapers or down to zero unless that's what the patient wanted, but really making a plan together to engage them in that care, set a foundation for greater success by the patient, but also to mitigate some of the harms and that may happen and with tapering too quickly. And lastly, I'll say patient engagement was a big part of this as well. So in parallel to the clinical practice changes that were happening with clinicians and how they have those conversations with patients was about what can we help the patients with in terms of materials around safe prescribing, their considerations, what is tapering, what does it look like, so they can participate in that shared decision making with their care team. So now I am very happy to introduce Rachel Mashburn from CedarSinai Medical Network. We interviewed them and highlighted one piece of their program. So in each of our sections, we have an innovative idea or two. And their program is very comprehensive, and I've invited her to share today, not just about what we feature in the toolkit, but their journey in general about strategies to work with patients with chronic pain. So Rachel.
Thank you so much, Crystal. I'm really excited to share what we're doing here at CedarSinai. So first slide, please. So I'm going to start with a brief description of our organization. CedarSinai Health System has three main arms: the medical center, the medical network, and academic affairs. The medical network is the outpatient arm of the health system. It consists of a medical group, an IPA, a hospitalist group, and 11 affiliates that represent different specialties. And what I'm going to be focusing on today is the work that we're doing in the medical network. Next slide, please. So this is a map of all the medical network offices. The CedarSinai, and kind of the middle of the slide, is where the medical center is located, and all of our surrounding medical network offices. We are primarily in West Los Angeles. However, we also have offices in the South Coastal region and also up in the Valley. Next slide. So this is just a very high overview of the different things we've done to approach the opioid epidemic. I'm today going to be focusing mostly on our chronic pain program, but I did want to highlight all the other work we're doing in this area, starting with the creation of an opioid steering committee, which consists of a broad multi-specialty and multidisciplinary team of both operations and clinicians. We also developed policies to help support our providers for having those difficult conversations with their patients, but also to outline best practices. In addition, we've worked with our data analytics team to develop dashboards, and we're going to use them as provider report cards to share with individual physicians and other providers who prescribe opioids. How are they doing? What number of patients are on greater than 90 MME, for example? They also have in their information on best practices. So does that patient have a pain agreement on file? Have they checked cures? Has there been a urine drug screen? Also, we've gone on what we are calling our education campaign. And we started with primary care physicians. Next, we're going to be going out and meeting with the different surgery specialties. And then this next bullet is what I'm going to be focusing on today is our chronic pain program, but also identifying all the other resources that we have available to our physicians to help manage pain. And lastly, we leveraged our electronic medical record for some of the things that Crystal just shared as well. Next slide. So this is our model for how we are managing chronic pain here at CedarSinai. The referral source is primarily primary care physicians, and they refer into our chronic pain program. And this is allowing patients to have many different options and resources available to them. But none of this would be possible without the leadership and support of our pain medical director, Dr. Joseph Tu. He is not only available to support our physicians, but he also supports this entire program. And some of the things, so I'm going to start with the top, and that's been really key to the success of our program is having his leadership. So starting with the top at the medication management, he primarily sees our very complex, difficult chronic pain patients that are on very high doses of opioids. And he'll either continue to see them or he will work to titrate them down to a safer dose. And then for patients that are stable and at lower doses, around 80 MMEs, they will be enrolled in our pharmacist-run chronic pain medication management program. And I will share a little bit more about these programs in the next slides. We also have two other pharmacist-led programs, which is an opioid taper program that primary care physicians and Dr. Tu can refer to, as well as a benzo taper program. The next step down, or the next bubble, is our functional restoration. And here we are contracted with different physical therapists and occupational therapists that the physicians can refer patients to. And I really want to highlight the value that we have on our team, our pain psychologist. She has been such a huge part of this team, not only providing her one-on-one consultations with patients to really discuss and address the behavioral elements of pain perception. She also provides group cognitive behavioral therapy classes around chronic pain and insomnia. And she's been so helpful in meeting with our physicians and the staff, empowering them and helping them how to appropriately engage patients around this difficult topic. Under addiction, we currently only have one physician in our network that does addiction treatment. This is something that we're hoping to scale in the future, and we're looking for other physicians that would be interested in training and becoming available to help in this arena. And then lastly, we also have Dr. Tu, who can also perform interventional therapies, as well as we have a pain center at the hospital that's available for that as well. So we really have multiple options for patients because it's not one size fits all, and we've definitely noticed that it's important to have a multidisciplinary team and a multimodal approach to the opioid epidemic. Next slide, please. So on the left-hand side is highlighting the work that Dr. Tu does in his chronic pain program, where he is where he's providing direct patient care. Again, he's seeing the complex chronic pain patients, those on very high doses of opioids with or without CNS depressants, and he manages them from there. Underneath his leadership and support, we have 3 pharmacist-led programs. So briefly, the one on the right is for the chronic stable patient. So this is a pharmacist-led program in the same office as Dr. Tu, where patients are required to sign an annual opioid agreement. We check a urine drug screen every month to 3 months, depending on the risk for aberrant behavior. We check cures monthly for these patients. We prescribe naloxone, and we, if everything is appropriate, then under our protocols, we are providing a 1-month medication for the patient's opioid. And the next slide, these are our 2 taper programs. So on the left is our opioid taper program, and on the right is the benzo taper program. Both also function under the leadership of Dr. Tu. The patients are referred to a pharmacist who has training in this. An agreement is also signed in both of these programs. Naloxone is prescribed, and then a very individualized taper plan is developed, and we follow them very closely. Sometimes we are calling people a few times a week because it's really important that patients don't have withdrawal symptoms. And so depending on how the patient's doing, we follow them very closely. And in some cases, it's just getting them down to a safer dose. It doesn't necessarily mean having them come all the way off of the medication. Next slide, please. So a little bit of data for our benzo taper program. This started in March of 2017. We've currently seen 46 patients, of which 22 are currently in process of tapering off of their benzodiazepine. 12 have successfully tapered off. 6 are tapered down to a lower dose. 5 were not able to taper, and 1 was only using their benzodiazepine intermittently, and so that was kind of deemed as far as needing to taper further. Next slide. For our opioid taper program, this one we just started in April of this year, so the numbers are very small, 9 patients total. We currently have 6 patients who we are actively tapering down. 2 are pending to be seen, and 1, the taper was initiated by the pharmacist and then will be continued with the primary care physician. Next slide. So lastly, I want to just summarize some lessons learned and some advice, if I could share. Really, I kind of mentioned this earlier, but managing chronic pain is definitely not one size fits all. We have to have many different options and a multidisciplinary team to really make this successul. I think I highlighted that how important it is and has been to have Dr. Tu as our physician leader. It's so valuable to have someone that has a line treatment philosophy and a breadth of experience. So not only on the interventional side, but also on the medication management side. PCP BuyIn is so important. We actually have a primary care physician who is taking a lead in this kind of work as well. And it's been so valuable to have all of the PCPs buy into, we do have a problem and how can we help support them. I did highlight how valuable it has been and continues to be to have a pain psychologist on the team around engaging and empowering providers and staff. From data is so valuable. I can't stress that enough. And so we've been working with our data team to create these dashboards, which we plan to provide to physicians on a regular basis so they can see who are their patients on really high doses, are they following best practices, and really help them plug these patients into the various resources I mentioned. Academic detailing, we are also going to be using for the physicians that have the patients on really, really high doses, and meeting with them peer-to-peer to help them, again, plug these patients into resources. And lastly, I didn't really get into this, but we have done a lot of work in our electronic medical record to address this initiative. I really appreciate the time, and I hope this was valuable. Thank you.
Great. Thank you, Rachel. A quick question while I have you on the line right now. So I think PCP buy-in is a common theme that we hear no matter what the improvement initiative is. So for you guys, what was most effective in getting PCP buy-in?
I think having a PCP champion and Dr. Tu actually go and meet with them. So we did with that education campaign and our Chief Medical Officer, Dr. Caroline Goldswag. So we had our PCP champion go meet with the physicians. We had Dr. Tu give presentations to the physicians and Dr. Goldswag, and then we plan to present these report cards to then meet with them and help them plug into the various resources. So I think having a physician champion that they respect and they work with closely has been very successful for us.
Great, thank you. And I just want to highlight the using the data that we share, and another common theme that we heard was about not using data to punish, right, or be in a punitive way or a judgmental way with clinicians, but it's really an educational tool and to expand the dialogue and about sharing those patient lists so that clinicians feel like they have the information needed to make decisions with their patients. Absolutely. Thank you, Rachel. So now I'm going to switch over to our other panelist, Susie Foster from Hill Country Health and Wellness. And so from my prior experience, I've always heard wonderful, wonderful things about Hill Country Health and Wellness, particularly around behavioral health and integration into primary care. And I was really inspired by their ideas, both in engaging patients with some of their materials, and then how they're bringing that into treating addiction and really using medication-assisted treatment. So Susie, share with us.
Thank you, Crystal. So my name is Susie Foster, and I'm a family nurse practitioner and the Chief Medical Officer at Hill Country Health and Wellness Center. If you want to go to the, yeah, perfect. So Hill Country is a small to medium-sized FQHC located in eastern Shasta County. We have about 6,100 patients for a total of about 34,000 visits a year, and about 80% of our patients are at or below 200% of the poverty level. The picture that you see there is our main site in Round Mountain, which is about 35 miles east of Redding. And just to give you an idea of how rural Hill Country, or at least our main site really is the nearest pharmacy or gas station is about 30 miles away. About 75% of our patients do drive 35 miles or more one way to see us at our main site. We do, in the last couple of years, have opened a few satellite sites. We have 2 medical satellite sites that are open 30 hours a week in Redding itself. We have 1 behavioral health, traditional behavioral health hour-long therapy site. And we have a walk-in urgent mental health site that's actually a county contract, so it doesn't have to just be our patients, it's for the entire community. And that's open 365 days a year until about 9 o'clock at night. Hill Country has been really integrated since its inception in 1985. Hill Country was founded by a doctor and our now CEO, who is a marriage and family therapist by training. So just by virtue of who the founders were, Hill Country has been very integrated since the beginning. Next slide. So I was really excited today to tell you about some of the different patient education materials that we've really taken on to help with our controlled substance management program at Hill Country. Hill Country's had a pretty robust controlled substance management program since the early 2000s. We've been doing drug screen or tox screens, and we've had an agreement for quite a while that the patients sign annually. In 2013, we started adding in, before patients are prescribed any sort of pain medications, they meet with one of our LCSWs for an hour-long safety assessment that looks at, using different tools, looks at our risk of prescribing to a patient and also the patient's risk of taking these medications, and really helps the LCSW and the patient kind of come up with a comprehensive plan of, if we're going to prescribe pain medications to you, how often do you need to be seeing counseling, or do you need to be seeing counseling, or what other adjunctive therapies can we add to your plan that will make this as productive as possible for all parties involved. In 2015, we had the opportunity to work with UC Davis Center for Design in the Public Interest, and it was a pilot project by UC Davis to use patient-centered design to come up with really patient-friendly information. And so we really actually started with reworking our pain management agreement. And it was very dry pain management agreement to start with. It was a 2-page, very wordy, was at a pretty high reading level. And we now, although it is longer, is a very interactive document where patients have the opportunity to write down goals, and that actually is started in that safety assessment that I talked about earlier. The LCSW talks about what goals the patient wants to come to in the pain management program. That's then shared with the primary care provider. And another really cool thing about the new agreement that we reworked is that there are some kind of frequently asked questions in the right column of the pain management agreement. So for patients to kind of have some food for thought and kind of spark some conversation with their primary care providers. And a lot of those questions have to do with kind of opiate overprescribing and overuse and those kinds of things. That agreement also covers narcotics, benzos, stimulants, and sedatives. What you see in front of you is what we hand out our new patient packets in. When patients call to schedule appointments, if there's any kind of notion that they're going to want to be seen for pain management at any point, the new patient packets get sent out in this folder, which UC Davis Dippy designed. The front cover on the right, or sorry, the left there, kind of outlines what to expect. So the first visit with the PCP is just to get to know you. We don't prescribe any medications typically at the first visit. The second visit is with the LCSW, and then the third visit is back with the PCP to come to a decision on whether we can prescribe or not. The inside is the screen that you see on the right there, kind of outlines some alternatives for pain, and also a little bit more about the process, about the random urine drug screens and those kinds of things that are involved in our program. Next slide. The other couple materials that I wanted to highlight for you guys today that we've had really good feedback on the left, we have the yellow book, some things you should know about opiates before starting a prescription. Not every patient gets this, but again, Dippy helped us put these together. And it really goes over in a 6th grade reading level, lots of kind of cartoon graphics and just really short snippets of words talking about what dependence is, what you should be looking for, what kind of issues opiates can cause. Are they safe? And then gives a spot, talks a little bit about benzos as well, and then gives a spot at the back to kind of write down questions and take notes. So again, not every patient receives one of those when starting pain medications, but the appropriate patients do. And then the blue book has been a really big win for us. It's 10 questions you might have about tapering your medications, and it really walks patients through what to consider when they're tapering. And the best thing about the blue book that patients really like is the last half of the book walks patients through kind of a self-support checklist and walks them through what they should expect when they're tapering as far as their function, their behavior, their symptoms, their feelings. Breaks it down into a green, yellow, red, so that patients can look and say, okay, I'm sticking to my taper plan that I decided on, I'm doing okay. Maybe if they say that their pain's, the yellow says pain's not always manageable. So it kind of walks them through what to expect, what not to expect. And then in the red section says, okay, if you're having specific symptoms with your functioning or specific physical symptoms, when should you call your provider? So patients have really liked that. I think they feel like they have something to refer to as far as what they should be expecting. The graphic on your right is actually a big poster that has 16 different interventions that are alternatives to taking narcotics. These are up in every single one of our exam rooms and up in our lobby. And we also have made flashcards for each one of those squares breaks down into a flashcard that we can give again to the right patients who that seems like that's a thing for them to consider. And the primary care provider can work with the flashcards with the patients on saying, pick out one of those that you want to work on, and let's work on that for the next month. And then maybe once they've accomplished getting out and moving a little bit, and they may pick another flashcard. On the back, where applicable, on the flashcards there are some local resources printed on them. Thank you. So for patients who the controlled substance management program or pain management program isn't right for them, or are really getting into dependent and addictive behaviors, we about 2 years ago now started a medication-assisted treatment program using Suboxone to treat opioid addiction. The MAT team for each patient at Hill Country consists of their primary care provider, their ex-licensed provider, who we try our hardest to have the primary care provider be the ex-licensed provider, especially if they come into Hill Country and we know that they're going to want or potentially need medication-assisted treatment. We really try not to have two different primary care providers involved, just because the patients tend to try to split and triangulate the team, and so it's better if you can just keep them in as one provider, but that's not always possible. Each patient also has a case manager and has an LCSW or behavioral health consultant at the facility who they can be in contact with regularly. Our MAT program is one of very high touches. Most patients start out in tier 1, where they see their primary care provider, or I'm sorry, their ex-licensed provider and or their primary care provider at least weekly. Sometimes that's more than once a week. They will be in touch with their case manager at least twice a week. Usually they're seeing the LCSW once a week for behavioral health therapy. And then we also expect them to be in an inpatient or outpatient treatment program or some sort of recovery support group. So it's a really intensive outpatient primary care program. It's not for everybody, but we feel like it's the right integration for Hill Country and for our patients. That first tier, we say it lasts about 6 weeks, but I have patients who have been in our MAT program for 8 months who really just can't get past that first tier. So tier 2, they go down to, we have office visits usually about twice a month. They're in contact with the case manager a little less frequently. And then tier 3 is monthly office visits. And quite honestly, we have very few patients who are in tier 3 because we really want them to be able to handle most of their stressors that come at them on their own before we're in that little of contact with them. So we've been doing, we can go to the next slide. We've been doing MAT, and like I said, since about October of 2016, so a little over 2 years now. I think that kind of some outcomes for us, I don't have a ton of data at this point. We're getting ready to kind of move into the data collection piece now that we feel like our programs are really up and going, and we feel like patients are in a little bit more stable spot, or our teams are in a more stable spot to support our patients. I think both our MAT program and our controlled substance management program really is a highly patient-centered approach, which builds really good relationships for us. Our patients in our medication-assisted treatment program who aren't ready and will kind of disappear, and because they're not ready, often come back to us. And I think that that's a big testament to the relationship that we're building when we are first meeting with them. The team approach, it just wraps around a lot of support around the patient and around the provider, because this is a pretty intense group of patients. And so that team approach really takes some of the responsibility off of the provider and gives the patient lots of different avenues and different people who they can connect with. We're a very, very, very harm reduction modeled approach, and so there are very few things that actually get our patients discharged from our program, and that's been a great approach for us as well, because it's creating very open relationships, and patients are able to tell us if they slipped up. About 70% we have about 70 patients in our MAT program right now, and about 60% are retained at 6 months. As far as next steps, we just recently hired a substance use disorder counselor to work at our really rural clinic in Round Mountain. We're going to try to do we are doing some groups down in Redding, but we're going to try to get some groups going up in Round Mountain and see if that doesn't kind of spark the program up there. It's been a little bit harder to get it started in the really rural area. So that's about all I can tell you for today.
Great, thank you so much, Susie. We have about 5 minutes left in the webinar, so if you have questions, go ahead and start typing those in the Q&A and we'll start addressing them. I know someone asked if these materials, the patient materials, are available. Those links are available in the toolkit, and they're on through an internet link, and they are in the public domain, and so you can use them. And there's several other materials there as well to highlight. So I'll briefly touch on, as Susie already touched on, the strategy 3 around treatment, and just that there's a lot of great data around where we have patients with opioid use disorder and the volume of buprenorphine prescriptions. And so really the strategies most effective are utilizing MAT to its fullest extent. And I was going to call out your attention to a great organization, the Center for Care Innovations, has been doing a program around MAT, and so they have a lot of great findings, and there's a deeper report that we link to. But if you want to learn more about starting MAT and creating those programs, if you have the resources, then that would be your go-to place. And then in stopping deaths, as Kelly mentioned, those are going up, and we see that there's still some pockets that have really high death levels. And so just to highlight that organizations, when they wanted to prevent overdoses, stop overdoses, is really about utilizing the EHR for alerts around both their risk of overdose and prescribing naloxone, and really working with patients to engage them in taking those prescriptions. Because one organization actually measured from prescribing how many patients actually fill those prescriptions, and it was only around 30%. And so they were thinking about ways to, some tools that they use to engage both their pharmacists and their patients in filling those prescriptions. Okay. Let's see, we have a question from April. Is long-acting naltrexone a part of this program? Our patients educated and offered all 3 FDA-approved medication-assisted treatment. I will defer to Susie or Rachel to share about that. And if Kelly, and if you had any thoughts as well.
This is Susie. We currently are mainly doing Suboxone. We've had a hard time getting long-acting naltrexone approved through our insurance companies up here, especially our managed Medi-Cal, so we're working on that.
This is Kelly. It's a really good question. Long-acting naltrexone is a carve-out in Medi-Cal, so it's not covered by the managed Medi-Cal companies. It has to be what's called a treatment authorization request direct to the state Medi-Cal program. So it's a little complicated for health centers to implement, but not impossible. And we certainly hope that the place we get to is that all 3 forms of medications are available to all patients who need them in their own local neighborhood without travel, but we're certainly a long way from that point.
Okay, thank you. And so I think Jerry asked in the chat about resources around prescribing naloxone. So that is in the toolkit in the strategy 4, and there's some resources from various organizations that they've used in terms of guidelines, some of the research, and then as well as engaging patients in that dialogue. Great, so any more questions, feel free to type those in the meantime, I just want to say thank you. Thank you to our faculty, Susie and Rachel, for being here today and taking time out of their busy schedules and clinical schedules to share this. And so it is amazing work, and they do so much. And if you want to reach out to any of them, here are our email addresses. If you'd like some more details, some more guidance, we welcome all those questions, thoughts, feedbacks, whatever you want to share. And in our last minute, help us improve. We're an improvement organization. Let us know whether today's webinar was a good use of your time today, and this helps us design future webinars to meet your needs.
So Crystal, thank you so much for taking us through the toolkit, and thanks so much to our guest speakers. We'll close the webinar. We do hope that this resource is a great support to all of your efforts to improve, and if you have resources that you would suggest we add, we always welcome those suggestions. So thank you and have a great afternoon.